place. Some of you may have seen this. This is one of them, comes out of the Gitlin group, the last author here. I think she sits in that status as the senior author probably on this publication. Has anybody seen this article? This is the one about community aging in place, advanced better living for elder care, for elders. She calls it CAPABLE. She always names her programs with an acronym. And what they did was they received some money from the Centers for Medicare and Medicaid Innovation. And their idea was to reduce the impact of disability. And they had a very, very small cohort, 281 older adults, 65 or older. Who knew that was old? Who had difficulties with their ADLs. And they intervened over a 5-month period. And 75% of the people improved in their ADLs and improved in their symptoms of depression. And they also were able to complete their IADLs, shopping and managing their meds. And that was over a 5-month period. There was something else I wanted to tell you about that. Oh, here's who provided the intervention. Who, guess? It was a team. I can wait you out. Who do you think was on the team? An OT. Who else? No social worker. Nurse. And who do you think the third one is? This is way out in left field, but just take a guess. A what? A handyman. Who made the, right? Who saw and made the landing. That is so cool, isn't it? All right, so I think your clinical practice, I think you should start your own systematic approach to practice using a data-driven approach. So if you could just hang with this, I hope you can find this interesting, but if you don't, I'll flick through the slides. So if you don't really like this one, I'm getting into it, just give me this kind of a signal, okay? So do you know about data-driven assessment? You know, I mean, this is the idea that, you know, data drives it, just like data drives which kind of diet you're going to get on, or what kind of car you're going to buy, or what kind of phone. It's a way of reasoning. You know, you decide on what perspective you're going to use, and that perspective, the model of human occupation, drives what kind of assessments you'll use. And you use those assessments, and then the model of human occupation drives what kind of goals you're going to write. And then it allows you to reassess and look at the outcomes, right? It's a nice, neat package. I have to tell you, when I graduated from OT school, we did not use theory to guide practice. We used techniques. We used the Bobath technique. We used neurodevelopmental therapy. We used psychoanalytic skills, right? I mean, but we did not have a theory. We did not have theories. In 1970, we didn't have theories. In fact, the reason why I went to graduate school, I graduated with my bachelor's, the reason why I went to graduate school was because it was like, when I finished, it was like, I still don't know anything about occupation. I know about NDT, and I know about Bobath, and I know about Brunstrom, and I know about Rood, but I don't, and psychoanalytic, did I know. But I didn't know anything about occupation. And it wasn't until about that period of time, like 75, 80, that the field became interested in thinking about a more organized approach to treatment that was not a medical model base, right? And that's why the model of human occupation came about. But that's for tomorrow. That'll make you come back. That's a commercial for tomorrow, okay? So this is a systematic approach. And this actually, these slides are work I did with Roseanne Schaff to give her the equal credit on it, where, you know, you first decide what's the problem, and then you decide how you're, you know, what perspective am I going to use? How am I going to conduct my assessments? I'm going to create a hypothesis about what I think's going on. I'm going to identify proximal and distal outcomes, and I'm going to analyze my outcomes, right? And I think if you could just do this with one of your favorite groups in your setting, 5-year-olds, 6-year-olds, kindergartners, people with right-sided strokes, people with left, orthopedic problems, knees, necks, backs, whatever. Just pick a small group and kind of do a journal, kind of do a map, do drawings, do whatever's going to make you really happy to look at the information that you're collecting and what you suspect will be the outcome. And you can be wrong, right? Or you can revise your outcome after day 3 or day 4 or day 5. But it gets you to really start to think about which ones of your hunches are good and which one of your hunches are off base. And it helps you start to eliminate some of the things that you're doing that you don't need to do and escalate some of the things that you're doing that are really working. All right, so that's what this does. And here's each slide that tells you about it. Do you want to read them? Not really, right? How far am I in now? 45 minutes? It's a quarter of the next hour? No, it's what time? Oh, it's 7:20, and I'm finishing at what time? Okay, all right. So this is what it is. What I just told you. Right? And then you get to write outcomes. You get to write outcomes. Like, you know, I think they're going to be able to do 8 reps. I think they're going to be able to do 16 reps. You have fun with it. This is a safe challenge that I'm giving you. It's private. It's about you and thinking about your work, okay? And pulling your work in to be tighter. You're going to measure outcomes, the ones that are really close. You're going to guess about them, like, I think she's going to be, you know, dressing in 3 days. I think she's going to be transferring in 4 days. Okay? And then I think she's going to be able to be discharged home as the distal outcome. But it really gets you into your work. And then these are all the ways to display it. Just like the diets got to display their data, you will get to display your data in all different ways. And I'm just showing you, trying to provoke you into thinking about ways to do it. Okay? And this is what when we have done this with therapists at Jefferson. We've put them through the data-driven decision-making model. And this is what they tell us. They you know, that they really understood. It really made a difference for them in their work. Right? It's helpful. I mean, I remember when I was a therapist, when I was a young therapist, I was like, what am I going to do? This patient's coming, what am I going to do with them? Why am I going to do it with them? And I would, you know, I worked actually at a place called Burke Rehab, no relation. And I worried about what I was going to do with my patients before they came. I mean, I knew the physical things I was going to do with them. As I said, it was in a rehab setting. But I didn't always have a reason for it, a reasoning. I didn't have access to that reasoning process. And I remember feeling panicked a lot of the time. And even I remember my supervisor, Margaret, who said, you can't act like, it was a therapy room. All the therapists had their desks in one room, and they were all like around the outside of the room. And she said, you can't act the way you act here if you want to work here, because you get so agitated about what you're going to do with your patient when they come. You get everybody worked up. Everybody's complaining about how agitated you get. So I really had no understanding, as I was saying to you, about why I was doing what I was doing. And so maybe you don't have that experience. But if there's anybody, if there's just one person out there that has it, I'm telling you there's hope. And this is the way to do it. Okay, this is the end of this group. References? References. So we can do the next one, which is really cool, which is about looking at, okay, so somewhere is my other notebook, my black notebook. Oh, it's right here. Yeah, never use a black notebook. I have lost this so many times. And by the way, when Mary Beth asked me to come, I laughed. When she walked away, I laughed and I said, February in Ohio? I don't think so. And so I told her that the next time we talked. I said, you sure you have this right? And she said, it always works, and you are the testimony to it. You were right, Mary Beth. Okay, so let's look at part 2, discovering OT's uniqueness. So I'm asking you, is there effectiveness data somewhere? Is there evidence of us being effective? I don't know. I'm asking you, I'm worried. Okay, so I'm doing this about the future of OT. I want to make sure that we're going to be there. Is there something specific about what we say and do? I kind of foreshadowed this for you at the beginning. Are there verbal and nonverbal components in the interactional work worth examining? And are they measurable? And will they help us with our effectiveness data? Okay, so that's where we're going. Okay, and here we are getting ready at base camp. All right, so here we go. So again, I'm not embarrassed about this one. I'm very proud of this one. Actually, I didn't know that this had been published in 2011. And I was sitting in a movie theater in Massachusetts, and it was a very chatty audience. It was at a film festival. And you say, like, what film did you go to? I went to this one. And this woman said to me, where do you work? And I said, Thomas Jefferson University. And she said, oh, really? I have a good friend, James Diamond, who works there. And I said, oh, really? I know him. I think I know him. And I went home and looked it up, and our article had just been, I thought, what happened to that article? And I looked it up, and it had been published. But this is a great article, and it's about, and I have it improperly cited in my CV. It's 2011, not 2010. But it's the evaluation of verbal and nonverbal communication skills in an ethnocentric OSCE. So, OSCE is the, does anyone know what an OSCE is? It's the Objective Structured Clinical Exam. So when you're in medical school, and at Jefferson, I was in an academic health center, so we did a lot with the medical school. And you send medical students into a room with a treatment room with an assignment. And so we have this building that has like 30 treatment rooms, and they all have cameras. And and it just has a plinth, an examining table, and blood pressure cuff, reflex thing. That's it. You send the medical student in, and you tell them what the challenge is. Come up with a diagnosis, whatever the challenge is. And you have trained somebody called a standardized patient. You've given them a script, and you've trained them for like 3 hours on how to act, what they're supposed to say, what their problem's supposed to be. Okay, and so this Lori Collins, the lead author, knew about my work in nonverbal and verbal behavior and was really interested in it. And she thought that, the literature supported the fact that communication during a medical interview plays a very large role in patient satisfaction. And I bet it's true in OT too, that the way we communicate. It also has been shown to play a very big role in patient adherence. Those are medical words, right? But to whatever you give them to do. So satisfaction in care, patient adherence, and it also affects their health outcomes, whether they get better. So it's interesting to think about this in light of the reduced hospital stay, that we have to communicate effectively in order to get adherence, satisfaction, and health outcomes. We also know from the literature that people develop rapport through verbal and nonverbal behavior, right? So well, I won't go into that. So our study, we had 19 medical students. We also had residents and fellows. And we had a 14-item verbal and an 8-item nonverbal checklist. And we also had a checklist that the standardized patient completed on the student. And we also asked the standardized patient to meet with the student after the encounter. Okay? And the challenge was the person was an older adult, and they had been diagnosed with high cholesterol. And in their last visit, they were told to start taking Lipitor. And this was a follow-up visit to see how that was going. And the challenge was that we wanted the students to be ethnocentric. We wanted them to appreciate the perspective of the older adult and be culturally sensitive to them. And in fact, the older adult was African American, so we wanted them to be particularly, and we taught them about ethnocentric approaches. And so the challenge was that how they were going to handle the fact that the person did not want to take the Lipitor. They had not taken it, and they wanted more time. And they wanted time to try a herbal supplement because they wanted a more of a natural approach. And they wanted, in fact, to take red yeast rice, which is, if you have high cholesterol, is a common supplement that people take. It's a statin without being a statin, without being processed as a statin. And so we wanted to see how they did. And we found out that, and we also taught communication strategies, all right? And so then we took videotapes of all these students and we analyzed them. And we looked at their use of verbal language, but we also looked at their nonverbal behaviors. We looked at whether they used their bodies to convey an interest, if they leaned forward or leaned in, if they made eye contact, and how they moved their bodies. We, talked about gestures and the importance of gestures. And we found out that our students did not do very well. They, many of them got louder and more persuasive with resistance. Some people got big. We had one medical student who he was sitting in a corner, a sofa, and he put one arm over one sofa and one arm over the other sofa, and just got like really big. And said, I don't know why you wouldn't want to take a statin. It's a proven drug. And people that don't take it when they have high cholesterol have strokes. So. And then we had some people who leaned in very close, maybe touched the person, listened, and gave them an opportunity to have a trial. Okay, and so then we asked as I said, we rated them and recognized, what kind of behaviors were the most effective for the patients, finding out that the verbal, but the nonverbal were equally important. All right, so that was a great study. That was a fun study. So now let's look, oh, and before I do this, I want to just say that I do think that interaction is, I think of interaction as a riddle. It includes the same parts and structure each time, right? It has a beginning, a middle, and an end. It can be new, but have an old familiarity to it. It can happen over a long period of time, like an hour intervention or a meeting, or it can happen very quickly in an elevator, in a hallway. It has a physical quality to it where you are in relationship to the other person, but it does not always require touch. It may have visual features such as eye contact or a common point of focus, and it may even have sound component, but neither are essential. It happens in starch proper formal settings as well as relaxed informal ones. So, you know, we're always interacting, and it's really fun. When I was a little kid, I lived in a small town that my mother grew up in, and she had a lot of cousins and sisters and brothers, and she went on a customary round of activity by foot every day and dragged me along, allowed me to accompany her on those trips. And in the daily occurrence, I learned about this idea of a rhythm of conversation, the movement of the speakers, how they closed in together when they were going to share something that was a bit more intimate, how they opened the group, the circle up a little bit when they wanted somebody to be able to signal that others could come in. They had different forms of greetings. Many of you may experience this in your daily lives. It's one of the things I really miss about work, because Philadelphia is a very, very friendly city. And like you talk to everybody. You know, you talk to the people on the train, you talk to the conductor, you talk to the guy who sells you coffee, you talk to the beggar on the street that you give, you know, your money to. You interact with everyone, guys in the elevator, you know, the person that's fixing the sewer out front of the building. Everybody talks to one another and interacts. It's a kind of a problem for me in a way, because like my family often tries to extract a bargain from me when I'm going out with them, like, are we going to stop and talk to everyone on the way, or are we going straight there? Or recently my son said to me, when we go as we were walking over the threshold into a bookstore, he said to me, don't talk too much, because they'll know you're not from here, right? And I've been experiencing this difference in interaction now that I'm spending time in North Carolina, because it's very different in North Carolina. The people are so nice and so friendly. At the airport, like 3 people called me darling this morning. Darling. You okay, darling? It's like, but they're very friendly and very nice. But it's a superficial kind of thing too, you know what I mean? It doesn't go too deep. You can't ask for too many directions. But I'm trying to pick it up, but I do feel like kind of like a foreigner. But I will say that I've only been in North Carolina for like, you know, a year, a little over a year. I know more people in North Carolina, in my neighborhood, than I know in the neighborhood that I also go to in Massachusetts, rural Massachusetts, where I have gone for 65 years. I know more people in North Carolina, because that's about how they interact. Because is anybody from New England here? Somebody is. Sorry. You know what I'm talking about, though. You I can offend. All right, so let's look at interaction. Okay, this is some of the literature on it. I thought you might be interested in it. I don't know. Kendon is about, you know, these patterns that occur, these natural occurrences. of focused interactions, where you look, where you speak, when you remain silent. This is what's so hard to learn. How you move, how you manage your face, how you orient to another person. You know, do you orient? Do you look at them? Do you give them full body? Not. How you position your face, yourself spatially. So that's in this work of conducting interaction, really interesting work. He does a couple of studies of like greetings at a birthday party or greetings at a cocktail party and the different formations that people make when they want others to join or stay away. Then there's the work about gesture. So along with facial and expressions, there's the use of the hands, the head, and the torso. So I'm Sicilian, and this is very important to Sicilians. And my son has a new friend who's totally Sicilian, so he's really picked up a lot, you know what I mean? So they use their hands, and they use their hands in very subtle ways. But when they really want you to get it, they, you know, have different ways of emphasizing it and pointing and telling you that they want to know it. Those of you who share a Sicilian background know what I'm talking about, right? You know what I'm talking about. So it's the way, you know, we greet one another. Huge amount of literature about gestures. I think that's important. That could inform us, all right? The sequence of the organization. Again, in the OT interaction, we are dominant. You run the interaction. You start it. You keep the rhythm and the pace of it. You own it. You are in charge of it. And you have to give the right kind of signals to people so that they know when there's an opening. And I'm sure you have people in your life like this who hold the floor. My husband has this new habit where he'll say, you know, what? Do we know what? I mean, I don't know if it's word-finding difficulties. I don't know if he wants the floor. He holds the floor. A lot of people say, right? It's hard to get a word in edgewise. Those are the people that are holding the floor. But we have to be careful not to hold the floor during therapy sessions. And we have to give clear cues about when it's the other person's turn to talk, okay? And we have to try not to bump into them. And then these are the old hallmarks about behavior in public places. If you're interested in this, you know, it was Edward Hall who made this all happen. And even though his literature is really old, it's really fun, and it's very, very relevant even today. And then this slide is up here just because I love Ph.D. And he shows you different ways to look at data. And it might be fun for those of you who are artistic and want to make the journals that we talked about earlier that you committed to. You know, you can draw. You can make pictures of, you know, how many elbows, how much range of motion, whatever. All right, so let's look a little bit at, you know, there's a lot about the doctor-patient interaction. There's a lot of literature about this. How many of you go to a doctor who doesn't make eye contact? A doctor who doesn't respond to certain questions? We'll talk about this in terms of OT as well, but you know, again, they own the space and they signal you when they're interested. We have lots of pictures of docs who may ask you a question and keep their eyes down like that, which means give me a quick answer. I don't want a lot of noise from you. Okay, so, and I have to say that I do think that the whole orchestration of the therapeutic experience is very artistic, you know, very artistic. And at one point I wanted to just tape sessions and put them to music, because you can tape like what goes on. I once taped what went on a playground and put it to music and just slowed it down to different speeds and got everybody to move in an organized, sequential way. So I think that's true about the therapeutic encounter. I think it's a beautiful experience that could be put to film, put to music. So let's see what these are. Okay, OT about interaction, we've been talking about that. Want to decode what's going on. This is one way to decode it. This is another study I did. I took a group of 4 occupational therapists, all working in early intervention settings, and I looked at, they all had entry-level education in OT, and then I developed individual profiles about each of them as I got to know them, and I saw that they had different kinds of specialty and advanced training, and they had different professional belief systems. So some of them thought like their point in working with a child who had developmental disabilities was to get the child to move. Or their point of view was, their personal belief system was that the most important thing was to approach the sensory system and regulate it. So our professional belief systems evolve from our advanced training and our experiences as clinicians. And then also is guided by theoretical perspectives and expertise, okay? So when I broke my clinicians down, I saw and interviewed them, I saw that that's what guided them. I showed them videos of them working with children, and I said, what were you thinking of when you decided to do this? And then I realized that the therapeutic interactive encounters was composed of verbal behaviors and nonverbal behaviors, and a co-participation of the therapist and, in this case, parents and young children. And that also the setting significantly affected it. So I taped some sessions in community sites and some settings in people's homes. And so the therapeutic interactional encounters look like a therapist who asks a question that leads to the next task, that leads to a new movement, and that leads to this, on and on. In other words, it perpetuates itself once you're in it. You know, it starts and has a self-perpetuating quality to it, which makes it a little bit hard to follow, and you'll find this out when you start examining your own practices. I don't know, have I mentioned this before? Because this is my favorite little triumvirate. Reciprocal, reflexive, and complementary. That's what interaction is. You say something and I respond to it. Reciprocally, but also reflexively in terms of what I think you want to hear and what automatically comes to mind. And it also complements what you said. So this is a place where I had a videotape of a woman in an elevator with a ferret. Did anyone see that commercial? And she's eating like something. And another person comes in the elevator and says, well, that's interesting. She's got it like in a baby pouch. And she says, yeah, I have one every morning. You know, they have like these parallel conversations where the person that's watching her is talking about the ferret, and the person who's talking is talking about this, whatever she's eating. And they're both like totally confused when they leave. And I think that lots of interactions are like that, parallel interactions. Okay, and the interactions are also based on social and cultural conventions, right? This is why I'm having so much trouble with my cultural conventions in North Carolina. Evidently, when you see somebody on their porch and they're sitting outside, you're supposed to go over and talk. Okay? And I'm like not that kind of person, but I'm doing it. I'm doing it. My neighbors were outside 2 nights ago, and I went over. Okay? So let's look at the fine-grained detail of OT. Okay? I think that during an OT encounter, there are indirect and direct requests that we make, okay, in an encounter. I think that our participants, your patients, are in a constant state of readiness. They don't know. Some of them are novices. They don't know what to expect. All right? Okay, so the new novice participant and I call them inexperienced participants. So a novice is somebody who's never had OT before, doesn't know anything about it, is pretty perplexed. You're asking me about, my home, what side of the bed I get up on, literally, where my bathroom is, how many steps it is. The experienced participant has had OT or another therapy of some sort and understands kind of the hidden meanings and what people say. So the response to the therapist's direct questions and clues are very different for the novice and the experienced participant. When there is no cue for the novice, the participant does not respond. So if you say to them something like, you're looking at the baby and you say, "Oh gosh, are you cold?" The novice doesn't know that what you're really saying to the mother is she cold or does she shiver like this all the time? She doesn't know, so she doesn't respond, or the father doesn't respond, without a cue. When there is a cue and the therapist asks a direct question, the participant that's a novice will provide a brief response. Yes. Not always. Sometimes in the morning. All right? Very brief response. That's a novice. An experienced participant needs 0 to 2 cues. They provide the detail or the additional information because they know what you're looking for. They've been around the block. They know you, like, for example, later on, I ask a parent, "Do you have a stroller?" And she says, "Yes, it has great back support." So that's a experienced participant, right? She knows exactly what therapists look for. Just here are some examples of the interaction that I tried to capture. And what I really wanted to find out in terms of how much eye contact therapists made, how many cues they gave, and how the parent responded. So in this case, this woman with the finger out is a therapist, and she's asking, does he use his pointer? When she asks, does he use his pointer finger without giving a cue, not everyone knows what the pointer finger is, right? Everyone won't respond to that. But when she gives a cue, there's a better chance that she's going to be able to elicit the kind of information that she wants. And I did choose to, use line drawings because when you use a video or even grab the video and just have the one shot, I think, it's kind of an invasion of people's privacy. Even though everybody, I had an IRB and everyone agreed to be in it. But it also distracts from what you're trying to pay attention to. So when I first showed these as video pictures, people would say to me, "I can't believe what that therapist had on." Or "I can't believe how much she had in that room." So I looked at the literature on video microanalysis, and it does say line drawings allow you to draw the attention to exactly what you want your audience to see. So let's look at this one. Here's again, this is an example of her forming and reforming interactional space. So, a minute ago, the little guy was just sitting on the floor, and now that she wants to see what he will do with another object, she decides to put him up at a table. This therapist was masterful in how she could form and reform interactional space. But think about that in your therapy, because we really are masters. You sort of have collected together the things you're going to use for the treatment, and you move them in and out rather quickly with almost sleight of hand to keep the person's attention or to keep the rhythm of the session and to get everything you want accomplished at that one session. Here's another, this is that same therapist using interactional space, and she knows that this little boy is very gravitationally insecure, very poor balance, very fixed, and she's trying to look, she can't help it, she wants to really get a good look at how he responds to movement. And so she lets him have the ball for a little while here, and then well, I wonder why I'm asking indirect questions here now. Let's go on. We'll come back to it because I want to show you this. Okay, this is about indirect questions. I can't go back and show it to you. It shows up later in the tape. What she does is she moves the ball away and puts a ring of different colored snapping blocks together in front of him. And because the mother knows, the mother is experienced participant, she's been around the block, she's had OT before, not with this therapist. She knows how much her child dislikes this and how he responds, right? He gets like crying, upset. The therapist puts down this ring of beads in front of him, and the mother says, "Oh, look at these beautiful colors." She totally distracts him. She totally moves in and does the scaffolding for the experience. Okay, so that's what an experienced participant can do. And I'm sure you have that too with family members who can help when their mother or their father is being seen, or their husband or their wife is being seen. So when therapists ask indirect questions, a novice who is unfamiliar with them misses the question, doesn't even respond. If they do respond, remember I gave you just that 1 or 2 word response. Yeah. How often? A lot. How often is a lot? 1 or 2 times a day, right? But when they're familiar with what's being asked of them, a novice participant will respond with a little more detail. But we went to this one family's house, which I'll show you. This mom, she had twins. Very, very, very difficult early childhood for the twins. They were in a NICU. And she was a nursing student, and she knew every oxygen level, every drug the child had been given, every test result. She was just totally embedded in the medical model. And this is an experienced therapist who's working with her, and I was taping. Actually, it was the first time I was taping this study, and in the middle of the session, the camera was on a tripod, and it went straight up into the room for the rest of the session, and I didn't get a lot. Anyway, this mom is shocked. I mean, the therapist couldn't see it. The mother was shocked, incredulous, that this therapist was asking her, "What are your goals?" Because she had been told for the whole early course of her child's life in the NICU by physicians and nurses what the goals were, right? Our goal is to get her off oxygen. Our goal is to get her to suckle. Our goal is she had never been asked what your goal was. And she was shocked. She was frightened. I think she sort of felt like, you don't know what the goals should be? If you don't know what the goals should be and you're the OT, how would I know what the goals should be? So it was interesting to see that reaction to it. And what happens is that when this therapist does not make eye contact, she does not get the kinds of responses she needs. But when she looks up at the person and gets eye contact, she gets a much longer response. So it's important for us to cue the kind of responses we want from people. To cue them, it's your turn to talk. You can even say, it's your turn to tell me. Okay? This is just showing you that now the mother's more engaged in that discussion. So how do novice participants gain experience? And they gain it by us teaching them, plain and simple. We teach them how to respond with detail. We start to tell them why we're doing what we're doing with them. I'm putting you on the ball because I want to see what your balance is like, because I know when you're in the kitchen, you're going to reach for a spoon to stir the soup, or you're going to want to you're going to reach for the glass in the cabinet, or you're going to pick your hands up off the counter when you fold your laundry, or you're going to lean over the bed when you reach for the covers. And that's why I'm putting you on the ball. Then the next time they came to therapy and you say, how are you doing? They say, I'm able to reach for my covers now, or I was able to get a glass off the first shelf. So we have to teach them about what it is that we're interested in and the kind of detail that we're interested in. And this is one of my favorite interactions. This was before we started taping the session. And when you do videotaping, you learn that you should start the camera rolling as soon as you possibly can. And that even when the interaction is over, you should keep it rolling, because some of the most important things happen before and after the action. All right? And this is before the action. They don't know that the camera's rolling yet. Because I didn't have one of those things that went, action! So this therapist is with this little girl, and this is her grandmother. And the therapist holds this little frame up to the little girl and says something like, I see you. And the grandmother, who knows, she's experienced, and who knows the kinds of things that this therapist has been working on and cares about, says, ask her to say her ABCs. And the therapist says, A, B, C, D, and the grandmother says, no, one at a time. A, and the little girl says A. B, and the little girl says B. See, so it's an example of understanding what's expected and giving people the space to be collaborators in the interaction so that they can really contribute in a complementary and reflexive and reciprocal way. I think that might be my last slide. Oh, ignoring topics. Oh, how could I forget? You ignore topics. You do. Does anybody feel they're guilty of it? When somebody brings up something that you don't think is any of your business or not in your frame of reference, you ignore it. Just like the doc ignores it when you say, I'm really feeling anxious lately. Or at least my doc always does. We ignore topics that we feel are outside of our domain of concern. So this therapist is working with this little boy, an experienced participant, the mother, and she's talking about, she's working on his mouth. She's working on closure and swallowing. And the mother, she's saying, how's he doing with eating? And the mother gets onto the course of what he's eating and how much he's eating and, in fact, his bowel habits. And the therapist doesn't feel that's within her domain of concern, right? She doesn't know about dietary nutrients. And so she, rather than saying, I think it's best for you to speak to, let's talk to the nutritionist on the way out, or let's talk to the nurse on the way out, she simply ignores the topic. And that's a signal that we have also. Oh, the next set of slides is about forming and reforming interactional space, which I've told you about. And this is about what it looks like when you do an analysis of how people are moving. Is that rain? Oh, I might as well slow down, because you're not going anywhere. It's about, just how dense an interaction is. So if you look at this, this occurs, The first number is the minute count, 1, and the second number is the second count, 33, and the third 2-digit number is the frame count, which I can't really explain. It's just the number of frames that are going by, and they don't coincide exactly with time. So it can just shows you how dense, what amount of things happen, what verbal things happen, what the therapist says, what the mother says, and what the movement is. And it's just an example to show you that encounters are very rich and very deep and very thick with not only meaning but with action and sound. Okay? And I think that's it for me. Oh, here's another example of them. I like them. When I was in graduate school, I used to do them on rolls of paper. So my whole house was like these rolls of paper, and I used to analyze these videotapes at every single thing, every word everyone said at exactly when they said it. And I realized I had done it too much when my son came into the room one day and was able to recite it pick it up exactly where it was and recite it word for word with the speaker. So I knew I had gone too far. That's when I knew the study was over. All right, so there we go, 8:08. 20 minutes left. What do you think? Does it make any sense? Would you consider doing it? Would you write a journal? Would you collect anything? What are your experiences? Yes. Would you like a microphone?
No, I can be loud.
Oh, yes, you can. Good.
We have about 50 OTA students here.
Can you hear her? Okay.
From Toledo, and I appreciate that we're at an OT program, post-psych. However, oftentimes OTAs say, I can't do that. I know that they can, but can you speak to that a little bit about OTAs, implementing research, helping decide if there's a reference? Because they'll love hearing it from you more than me.
Okay. Well, it's funny you brought it up because yesterday my husband said to me, as if I didn't know, he said, do you realize that the therapy cap's been lifted? I said, yes, I do. In fact, I contributed to that effort for years. Money. Haven't you noticed those checks? And he said, well, you know, OTA isn't going to get as much. I said, yeah, I know OTA isn't going to get as much. He said, are you comfortable with that? Or should we be writing in about this? You know, should we be pressuring? And I said, we work so hard to get that cap. But we got into a whole long discussion about what it is that OTAs do. And they really are the engine of occupational therapy. I mean, and I think especially with where we're getting with cost containment, that OTAs will be more and more important because they will be able to deliver the therapy. I definitely think that because of their boots on the ground perspective, that they are able to collect exactly the kind of data we need, counted. And I don't know, if the word data is threatening, don't use it. Use counting, you know, the numbers of things that you see. And I always think that the people that are delivering the care are the richest places to find the research questions. But I suspect that if you want to talk with an OTA about getting started, or if OTAs want to talk to each other about getting started with this, you pick your favorite population. You know, you pick your favorite people, you pick the part that you love the most, and that's what you start counting. You know, how many times at the end of the session, in the last 5 minutes of the session, does the person do? Or at the end of the sequence of activity that you're doing, how many times do they do it? Just count it and write it down. And then the next time, just count it and write it down. And you can also make some kind of field notes if you want to, saying This was a particularly good session. It was in the morning. It was on a Monday. It was on a Friday. Mrs. Smith said she felt good today. It's valuable, rich material. I think what happens is that when you become, inquisitive person, you start to write down all kinds of things, and you don't make judgments about whether they're important or not. You write them down because you collected them, and they are important. You're going to make sense of this, however you want to do it, whether you want to draw pictures of it, or graphs, or bar graphs, whatever you want to do. Bar graphs are real. I still do bar graphs on graph paper with colored pencils, because I love it. I just love it. And I made a bar graph of, well, I won't tell you. You'll think I'm crazy. So I think OTAs are a rich source of information for data collection. And what you need is just what happens local in your clinic. You make a bar graph about, well, when you come in with this problem, the last 5 patients I saw who had the same problem that you had at about the same acuity that you had came in with this dosage. They got 3 days a week for 15 minutes, and they improved this much. That's the local information, and what's local for you is all that matters, right? But you need to show change. People want it. People really want it. All right, who else has a good, thoughtful, meaty, meaningful comments? Do you think it's worth pursuing verbal and nonverbal? Have you ever done it? Have you ever seen novice versus experienced patients? Yes.
I would just make the comment that when you first asked the question early on about what makes the OT interaction.
Can you hear her? Yeah, they hear you.
The very first thing that popped into my head that I think does relate to the novice and experienced participant was self-esteem. Because I think that in those novice experiences, when we see them not reacting or not coming up with the answer we were expecting, we teach them through our next sentence, and that's what helps to make them experience. We give them that self-esteem that allows them to act on behalf.
Absolutely. Absolutely. Right. So that might be worth tracking too, right? Novices, how much do they need? Do certain kinds of patients need more I'll call it positive feedback. Do they need more? When do they need it? Do they need it more at the beginning of the session or the end of the session? Is there a difference in age, how much people need? Is there a difference in gender, how much people need? Is there a difference in how debilitated they are, how long they've been in the hospital, so forth and so on, right? Whether it's chronic, whether it's reoccurring. I mean, they're totally open. But I think you're right. I mean, that is something that we do. We make people feel good, right? I mean, if I don't feel well, there's no place I want to be except with a bunch of OTs, right? Because I'm going to be fine. I'm going to be fine. I like to travel with OTs because nothing's going to go wrong on this trip. I went to Peru. I went to Machu Picchu. I went up how many thousands of feet? I had whatever you get, altitude sickness. Nothing happened to me. I was with OTs. Had a good time. Yeah. So that's a very important thing. What you say. Pay attention to what you say and what you don't say, but more what you say. Yes?
So for OTs that are working in a medical model, do you have any suggestions on even nonverbal ways that we can assert ourselves as as a mid-level practitioners? Like I'm saying,
Yeah, well, first of all, I mean, I would say I can't be interrupted. We can't stop at this point. I can't be interrupted right now. I understand what you have to do is very important. It's very, very easy to intimidate a resident. You know, they're so they're the easiest, especially in July. July 5th, my favorite day. You know, they just start their rotations. I mean, you just say, look, I can't stop this now. I'm sorry, I can't stop now. I think it's how you hold your body. I think it's that you turn to them. I don't think you stay facing the patient and say, not right now. I think you turn and say, we cannot stop right now. Okay, we're in the middle. You know, we've done a lot of preparatory work, and now we're at the middle, and I can't interrupt it now at this point. You know, and I think you pull them over on the side. I think you see them in the elevator and you say, hey, you know, you always are interrupting my sessions. You can't, because it's very disruptive. You have to understand that you are undermining my work. You are making it appear that your work is more important than my work. And therapy is very important. Have you seen the readmission data? I mean, I think, you know, I think you get big. Just like they get big, you get big, too. And I think that's something that we don't do. It really, I mean, I can't tell you how many times I'm in a team meeting and the therapist, you know, slinks in, sits in the corner, doesn't make a lot of eye contact, doesn't take up a lot of space. And I have other people that come to meetings, not only do they take up a lot of space, but they put things out to take up their space. I have one guy that I work with, he puts things out. He's a little guy. But really, I mean, he takes up a lot of space. Like, what's this about? So you have to, you know, you have to really, again, use your observations for what happens in meetings. Where you sit, what you say, what you look like, all matters. And I've always been told by my bosses that they think I really get it. You know, I remember when I started to talk about leaving Jefferson, you know, retiring, they said, well, I had just had this new president and a new provost, and they said, I hate to see you go because you're one of the ones that really gets it. And I thought, they think I get it because I'm always like, but I was always engaged. You have to be engaged in the conversation, and you can't sit at the edge of the table. You just can't. You can't come late, and you can't leave early. What's that saying? If you're not at the table, you're part of the meal. I think that's true, and I think, you know, it hurts the way we do therapy, too, because we do it in these large spaces. It has a disorganized quality to it. You know, somebody could be over here doing this and somebody could be over here. It can seem disorganized. And you can say that too, you know. I know it might not look like we're doing something here, but we are. But I would not let it happen, and I would pull them aside and bring them down to size. But they're the easiest. Fellows are a little more difficult, but still you can. Right? They're nervous wrecks. They don't know what they're doing. And they pick on us because they think that they can be superior to us. Because they can't be superior to the nurses, and they can't be superior to the speech therapists. Are any speech therapists in here with their bracelets? They can't be superior to speech therapists, and they can't be superior even to PTs. They can't, right? So they pick on us because they need to feel a little bit of superiority in their downtrodden lives. I think. That's my point of view. After I saw the videotapes of how they conducted the interaction, it really made me change. It really made me change how I thought about them, you know. If you don't get your way, just talk louder. Get bigger. But getting big is very important. Practice getting big. taking up space, holding your hands like this, watch how you sit normally, and then, work on getting big at places. It's good to take yoga so you learn how to have your heart space bigger, back out. So, I'm serious. I think it's really important. And I'm not alone. What else? Anybody else have something?
I think sometimes when we ask,
Can you hear her? You can hear her okay?
I think sometimes when we ask clients or families what they want, we're some of the only professionals that do that, and it shocks them. They're not used to that.
They're not used to it. When we ask people, what do you want? What do you expect to get out of therapy? I think they are shocked. And I think sometimes it might hurt us. Because like I said with that one therapist, I think they could think, you don't know what you're supposed to do, and I'm supposed to tell you? So I think then you have to construct that information I think you have to give that background. In OT, we collaborate. What we want to do is focus on the things you have to do. So you don't have to tell me today. I want you to think about it. Go home, think about it. What do you really want your child to do? What do you really want to be able to do? That kind of thing. I think it's very important. But we never give that information. And I think it also would help to say, we're different than everybody else. We really contribute something that's extremely unique. And I'm so glad you're here, and I'm so glad we're going to be able to do this. We have to sell it, too. And I don't think it's selling it in a false way at all. But, I think it's just giving full information. And that's, I think, what we failed to do, or at least our generation failed to do. I'm not sure if this next generation's doing it. Yes?
There are situations where the clients truly don't know what they want as a goal, and then even with prompting and them trying to think things, they just don't have a goal, or it's just something that's so not realistic that it's nothing that you're going to be able to accomplish. And what do you do in this situation?
I think there's lots of situations like that. I think there's more situations like that than not. I think people are so overwhelmed with what's happened to them. I think people don't have the facility with language. I think basic language, people don't know how to express themselves, don't know how to put it in words, what they're thinking, don't know, are scared, and are afraid to hope that they would be able to do things. I think it's everything you said. I would agree with you completely.
So what would you do in this situation?
I think I would probably get close, get my face, nice and close, feel comfortable. I think I might touch the person on their arm or their hand, most likely, and I would say, I'm going to tell you something I think you really could do. I'm going to tell you where I think you're probably going to, shine at this, probably put me to shame, but this is where I think is a really good, safe place to start. Let's try it, and scaffold that and really give them that, the safety that you are going to make sure, I am going to make sure that you succeed at this, and build that. But I think, we also are dealing with issues of self-esteem, that came up earlier, where people have poor self-esteem before they had whatever happened to them. People have hopelessness and helplessness in their lives. But I think, it's so rewarding to be able to believe in somebody and make something happen for people. But you've got to make it really simple for you, because you've got to succeed, right? So it's got to be something is going to be like so easy to do. they're for them, and that they're going to start. And I think it's trust. And I think it's how you choose, you and I may have different ways that we, choose trust. I use a lot of, I think it's self-efface, I use a lot of things like, this might sound crazy. I use a lot of humor and things like that. That's what works for me. That might not work for you, but I think having a genuine moment of believing, is important. I saw someone else's hand go up before. No? Going once. Going twice. All right. Sold to Mary Beth Dillon.
Thank you, Janice. Okay, so thank you again for coming. A couple housekeeping things. Save the date. Next year, you ready for the date? Thursday, February 14th. We'll all wear little hearts. February 14th and February 15th. We actually are planning to have Tina Champagne be our featured speaker. And we are also working with her to try to do a potential workshop during the weekend. So clinicians, if that is something that might interest you, just kind of keep that in mind. For people who are not students, your continuing ed certificate should be out to you by the end of March. So we're right in the middle of admission season. So give us till the end of March to get your continuing ed certificates out. If you do not have one by the 1st of April, please email our office. If you're coming back tomorrow, we will be in the same spot tomorrow. Okay? So thank you very much, and hope to see a lot of you again next year or tomorrow.